Walking into a patient's room at 2 in the morning, when the unit is dead quiet, is always a specific kind of feeling.
Oh, yeah, it really is. It's just you and the hum of the monitors.
Exactly. And everything seems fine, but then you notice the rhythm of their breathing is just a tiny bit off. Or you shine your pen light, and a pupil that was super brisk an hour ago is just, slightly sluggish now.
Yeah, and spotting those tiny, microscopic shifts is honestly the entire essence of critical care. I mean, clinical experience shows over and over that noticing a sluggish pupil is literally the difference between intervening early and, well, running a full-blown code blue.
Right, which is exactly what we're getting into today. Welcome to the Super Nurse Podcast. I should mention right up front that this show is created by Brooke Wallace.
Yes, the amazing Brooke Wallace.
She is a 20-year ICU nurse, organ transplant coordinator, clinical instructor, and a published author.
And just to be super clear, we are not Brooke.
Right, we are definitely not. But this entire conversation is built directly from her bedside knowledge, her clinical notes, and her signature teaching style.
Basically, we're taking everything she knows to help nursing students and new nurses bridge that huge gap between, passing a multiple choice test and actually keeping a real human being alive.
Exactly. And before we get into the heavy physiology today, definitely make sure you subscribe and watch the video version of this episode on YouTube. The link is right down in the description on our channel called Super Nurse AI.
Yes, definitely go subscribe. Because today our mission is the neurological system.
Oh man, Neuro.
I know, right? We are decoding exactly what the next-gen NCLEX RN exam is testing, but we're stripping away all that dense medical jargon. We want to show you why these concepts actually matter when you are standing right in front of a patient.
Because let's just address the elephant in the room right away. Neuronursing feels incredibly intimidating.
It really does. It's terrifying at first.
Yeah, you open a textbook and the neuro chapter just looks like an alien language. But to recognize a catastrophic neuro disaster, you have to know what normal looks like first.
Exactly. And that starts with the body's wiring system, which is the 12 cranial nerves.
Right.
And what we know from practice is that you don't just memorize them to pass a test. You learn them so you can quickly spot when a specific wire gets crossed or, cut entirely.
Yeah, and to make those 12 nerves less daunting, I always think back to that classic mnemonic from nursing school.
Oh, which one?
The, to touch and feel very good velvet AH.
Yes, a total classic. I love that one.
Right. Olfactory, optic, oculomotor, trochlear, trigeminal abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal. It's a mouthful, but if you categorize them into sensory, motor, or mixed, it gets so much easier to digest.
It really does. And connecting that textbook list to the bedside usually starts with the eyes.
Yes, the eyes tell you so much.
They do. Like when you shine a light in a patient's eye and check PERRLA, pupils equal, round, reactive to light and accommodation. When you do that, you are heavily testing the oculomotor nerve, which is cranial nerve 3.
Right, so if a patient suddenly has a drooping eyelid like a ptosis or they're complaining of double vision, that is a huge red flag.
Exactly. It means the wiring behind those specific muscles is glitching.
And then moving down to the face, we look at the trigeminal and facial nerves, so cranial nerves 5 and 7.
Yeah, trigeminal handles sensation and chewing, and facial handles your expressions.
And testing this at the bedside is honestly so simple. You just ask the patient to smile, puff out their cheeks, or clench their jaw. Like if they smile and one side of their face just stays flat, you instantly have a localized warning sign.
You really do. But out of all of them, we absolutely have to talk about the vagus nerve, cranial nerve 10. It is the absolute superstar of the group.
Oh, 100%. It just wanders everywhere.
Right, it wanders all the way from the brain stem down to the heart and the gut. And at the bedside, assessing it is as simple as checking the gag reflex and having the patient say, ah.
And that gag reflex is so critical, which actually ties perfectly into how we assess overall consciousness using the Glasgow Coma Scale, or the GCS.
Yes, the GCS is everything in neuro.
Because at the bedside, how do we quickly universally quantify if a patient is getting worse? Like, we need a reliable number.
Right, so the GCS ranges from 3 to 15. It scores eye-opening, verbal response, and motor response. So 15 is a totally awake-oriented person.
All right, and a 3 is just deep, profound unresponsiveness.
Exactly. But the absolute crucial NCLEX and bedside rule you have to burn into your brain is less than 8, intubate.
Less than 8, intubate. It rhymes so you can't forget it.
Yes. A GCS of 8 or lower means they're in a severe coma. And those airway protective reflexes we just talked about, like the gag reflex from the vagus nerve, they are Completely gone.
Meaning the patient literally cannot protect their own airway from their own secretions or from vomiting. So securing that airway is the absolute priority.
Exactly. So, okay, now that we know how to assess the baseline, we have to talk about what happens when something actually goes wrong inside the brain.
Right, because the skull is literally just a rigid box.
A very unforgiving, rigid box. Any swelling in there is a massive emergency.
Yeah, and this brings up the Monroe-Kellie hypothesis, which sounds like a physics lecture, but it's really not that bad.
No, it actually makes a lot of sense when you think about it practically.
Right, I always think of it like a rigid pressure cooker. The skull only holds three things: brain tissue, blood, and cerebrospinal fluid, or CSF.
And since that space cannot expand, if one of those three things increases, the other two have to decrease, or the pressure spikes dangerously high.
Exactly. And normal intracranial pressure, or ICP, is 7 to 15 millimeters of mercury. Anything over 20 is an absolute crisis.
It is. But what we know from practice is that experienced ICU nurses, they do not wait for the ICP alarm to go off. They are watching the patient for those really subtle early signs.
Like what? What are they looking for?
They're looking for things like unexpected restlessness. Or maybe the patient is suddenly irritable for no clear reason, or their headache gets worse, or their GCS drops even just a little bit.
Because that means the pressure is squeezing the blood vessels and the brain is literally starting to starve for oxygen.
Right. And if you miss those early cues, you get into the late signs, which are terrifying. The biggest one is Cushing's triad.
Oh man, Cushing's triad. If you see that, herniation is practically imminent.
It is. The brain is literally being pushed down through the base of the skull. It's a desperate reflex by the body.
So Cushing's triad is three things: systolic hypertension with a widening pulse pressure, bradycardia, which is a super slow heart rate, and irregular respirations.
Yeah, like Cheyne-Stokes breathing. The mechanism is wild, too. The blood pressure shoots up because the heart is trying to force blood into the skull against all that massive resistance.
And then that pressure crushes the brainstem, which houses the vagus nerve centers, causing the heart rate to just plummet.
Exactly. And since the brainstem also controls breathing, crushing it causes those chaotic respiratory patterns.
You also see posturing in these late stages, right? Like decorticate versus decerebrate.
Yes. So decorticate is when the arms flex tightly inward to the core. That means there's damage to the cerebral hemispheres.
Right, they pull to the core.
Yeah, exactly. But decerebrate is actually even worse. That's when the arms extend straight out. It means the damage has reached deep down into the brainstem.
So when the pressure is building like this, how do we actually treat it at the bedside?
First thing, elevate the head of the bed to 30 degrees. You have to use gravity to help drain the blood out of the head.
Right, and you have to keep the neck perfectly midline. Because if their head is slumped over to the shoulder, you're just kinking the jugular veins and trapping all that blood up in the skull.
Exactly. You also want to avoid frequent suctioning. Suctioning makes them gag and cough, which spikes their intrathoracic pressure, which directly spikes their intracranial pressure.
So no unnecessary suctioning. And pharmacologically, we're usually hanging mannitol, right?
Yes, mannitol is the go-to. It's an osmotic diuretic. Because it's this super hypertonic sugar, it acts like a molecular sponge in the blood vessels.
So it literally pulls the extra fluid out of the swollen brain tissue and into the bloodstream.
Right, so the kidneys can pee it out. But here's the massive bedside catch. You have to watch the lungs.
Oh, because of fluid overload?
Exactly. You're rapidly pulling all this fluid back into the vascular space, which dumps a huge volume load on the heart. If the heart can't pump it fast enough, the fluid backs up into the lungs.
So if you suddenly hear crackles in the lungs after giving mannitol, you might have lowered the brain pressure, but you just bought yourself a pulmonary edema emergency.
Exactly. It's always a balancing act. Now, transitioning a bit, if a patient has a severe headache and altered mental status, we have to find out why.
Right. Could be an infection like meningitis.
Yeah, and to confirm that,
Yeah.
we need to look at the cerebrospinal fluid, usually through a lumbar puncture or an LP.
Wait, okay, hold on. We just said the skull is a pressure cooker. If the intracranial pressure is super high, is it actually safe to tap into the spine and let fluid out?
Oh, absolutely not. That is a massive contraindication. If the ICP is too high, doing an LP is incredibly dangerous.
Because it creates a low pressure release valve, right?
Exactly. The high pressure in the brain will just vacuum downward toward the lower pressure in the spine, and the brain will herniate.
That is terrifying.
Yeah.
But assuming the pressure is safe and they do the LP, what's the bedside care for that?
So before the procedure, definitely have them empty their bladder. Then position them either tight, in a fetal sideline position, or sitting up, leaning over a bedside table. It literally spreads the vertebrae apart.
And then afterward, they can't just get up and walk around, right?
No, not at all. They need to lie flat and supine for like 1 to 4 hours. We want a clot to form so the CSF doesn't leak out. If it leaks, they get a notoriously awful spinal headache.
Right, and they need tons of fluids to help replenish everything. So what if that CSF comes back cloudy with high white blood cells and really low glucose?
Then you are dealing with bacterial meningitis. The bacteria are literally eating the glucose in the spinal fluid for energy.
Wow, that's wild to think about. What's the absolute first thing a nurse should do?
Droplet precautions. That is your absolute first priority to protect yourself and others. They stay on those precautions for 24 hours after the right antibiotics are started.
Okay, but you have to get the blood and CSF cultures before you actually start the antibiotics, right?
Yes, 100%. If you give antibiotics first, you can ruin the cultures, and then the lab has no idea what specific bacteria they're fighting.
Right, and at the bedside, these patients look really sick. High fever, horrible headache, and neutral rigidity, which is that super stiff neck.
Yeah, and they'll have photophobia too, meaning light just kills their eyes.
Yeah.
You also see Koenig's and Brzezinski's signs in the textbooks.
Right, like flex the hip and straighten the leg, and they scream in pain because you're stretching those inflamed nerve roots.
Exactly. Though honestly, while those are textbook classics, clinical experience shows they aren't always super reliable in every real-world patient.
Sure, that makes sense. But the main thing is keeping their room dark, quiet, and really neuro-friendly. You do not want to trigger a seizure.
Absolutely. Sensory deprivation is key for them. But sometimes, the neuroemergency isn't an infection at all. Sometimes it's a sudden vascular crisis where time is literally tissue.
Right, like a stroke, a CVA.
Yeah.
And the standard assessment for that is FAST, right? Facial droop, arm drift, speech impairment, time.
Exactly. But applying left versus right brain logic really helps you at the bedside.
Oh, I love this memory trick. Left brain equals language and logic. So a left-sided stroke causes dysphagia and right-sided weakness.
Yes, and right brain equals reckless.
Right, so impulse control issues, terrible safety judgment, and left-sided weakness.
You got it. But here is what trips up newer nurses. When a patient suddenly shows those stroke symptoms, clinical experience dictates 2 immediate actions before you even think about stroke meds.
Oh, right. Number 1, check a blood glucose level.
Yes. Why do we do that?
Because severe hypoglycemia can perfectly mimic a stroke. The brain doesn't store glucose, so when it runs out, parts of it just power down, and you get slurred speech and unilateral weakness.
It's crazy how similar they look.
Yeah.
You give them some IV dextrose, and the stroke magically disappears.
Right. And if the sugar is normal, the second thing is getting a stat CT scan of the head.
Yes, because you have to know if it's an ischemic stroke, meaning a clot, or a hemorrhagic stroke, meaning a bleed.
Because if you give a clot buster like TPA to a patient who is actively bleeding in their brain, it would be absolutely fatal.
Exactly. The CT scan is the only way to know for sure. Now, speaking of crazy vascular emergencies, we have to talk about spinal cord patients and autonomic dysreflexia.
Oh, AD is so intense. This happens in patients with a spinal cord injury at T6 or higher, right?
Yes, T6 or higher. The patient will suddenly get a pounding headache, their skin gets super flushed and sweaty above the injury line, and their blood pressure just skyrockets.
It's like dangerously high, like 220 over 118 high.
Yeah, it's terrifying.
So what should a nurse instinctively do first when they see that?
The absolute reflex action is physical. Do not lay them flat. Sit the patient up immediately, straight up to 90 degrees.
Oh, to use gravity to drop the blood pressure in their head.
Exactly. You are mechanically trying to prevent them from having a stroke while you figure out what's wrong.
And the trigger is usually something painful below the injury, right? Like a distended bladder from a kinked Foley catheter, or maybe a severe fecal impaction.
Yes. The body senses the pain, but the signal can't get past the spinal cord injury. So the sympathetic nervous system just panics and clamps down all the blood vessels below the injury, which shoots the blood pressure up.
So you sit them up, and then you immediately go hunting for the trigger before you even touch antihypertensive meds. Unkink the catheter, check the bowel.
Exactly. Fix the root cause. Now, whether a patient has a stroke or meningitis or increased ICP, the ultimate short circuit for the brain is a seizure.
And watching a patient seize for the first time is incredibly scary. It just violates every human instinct.
It really does. Your instinct is to hold them down or try to stop the shaping.
Right, but you absolutely cannot do that. You will dislocate their shoulders or tear their muscles.
And do not put anything in their mouth, no tongue blades, nothing.
Right, they will break their teeth on it, and then they'll choke on their own broken teeth.
Exactly. The strict safety protocol is all about the environment. Turn them on their side to protect their airway and let the saliva drain out. Pad the side rails, move the furniture away.
And just time it right. Most seizures stop on their own. But if they don't, and they go into status epilepticus, it's a massive crisis.
Yeah, status epilepticus means the brain is just firing continuously and burning through all its oxygen and glucose. To stop it, we push meds like IV lorazepam.
Which is a benzo, so it basically enhances GABA, the incubatory neurotransmitter, and just slams the brakes on the electrical storm.
Exactly. And honestly, bringing all this together, that is what neuronursing is really about. It's not just memorizing 12 nerves or a Glasgow score. It's connecting all these dots.
Right, like seeing that a pupillary change means pressure is building.
Or a stiff neck means a possible meningeal infection.
Or a massive blood pressure spike in a paralyzed patient means you better sit them up and unkink their urinary catheter. Everything is totally connected.
It is. Neurology is complex, but when you break it down into what you actually see and do at the bedside, it makes complete sense. You are learning how to think, not just what to memorize.
Exactly. And the most practical takeaway from all of this, always, always protect the airway first. If that GCS is less than 8, you intubate. And trust your gut when you see those tiny, subtle changes in a patient's level of consciousness. It is always the earliest warning sign.
Yes, trust your gut. And here's one final thought to sort of mull over before we go.
Yeah.
Think about how resilient the brain actually is. We spend all this time in the ICU trying to stop the damage, stopping the pressure, busting the clot, stopping the seizure.
You're right.
But the real magic happens later with neuroplasticity. The interventions you do at the bedside don't just save tissue. They actually give the brain the foundation it needs to physically rewire and heal itself over the coming months. It's incredible.
Wow, that really is incredible. The impact you have as a nurse in those first few hours is just massive. Well, thank you so much for joining us for this episode. As always, remember to subscribe and watch the video on YouTube on the Super Nurse AI channel. We want you to get all the content you need for the NCLEX and for the real world of nursing. See you next time.